first time. So,
No, second time.
second,
No, that is his third time.
third time. Oh,
Third time है ना प्रकाश?
Yes.
ना तो बची तो.
Okay, sir.
सर हमारा मतलब first time है तो you should introduce again.
I am Dr. Prakash. I am working here as a consultant laparoscopic and GI surgeon for last 1.5 years. I did my MBBS and MS from BJ Medical College and my fellowship in GI surgery from Gangaram Hospital, Delhi. So my today's topic is asymptomatic gallstone. So should we manage it or not? Now it is the gallstone in the absence of any symptom which is related to gallstone. But it is increasingly diagnosed nowadays due to widespread use of ultrasound. For many vague complaint or unrelated complaint, we are doing ultrasound abdomen or just a part of routine screening and at many institutes or some other surgery also they are doing routinely ultrasound. And also in health checkup nowadays, health checkup is also increasing. So we are diagnosing more and more gallstone, but 50 to 70% are asymptomatic at the time of diagnosis. The problem is only definitive management is cholecystectomy. So whenever the patient with gallstone and specifically asymptomatic gallstone comes, there are few questions they all have, like will they become symptomatic? Will they cause any complication? Will they cause gallbladder cancer? This is the most dangerous question, because others complication we can also manage, but the gallbladder cancer it present in the advanced stage. Primarily, most of the cancer are asymptomatic, and whenever they are in stage 3 or 4, we get to know about it. And the question is, should the gallbladder be removed and at what time? Also, the risk versus benefit of removing the gallbladder. So, what can be the symptoms of this gallbladder stone? It can be a biliary colic when it obstructs the cystic duct, or cholecystitis. Then when the stone passes into the CBD, it can choledocholithiasis, or it obstructs the CBD, then it becomes obstructive jaundice. When it is infected, it is cholangitis, and biliary reflux into the venous system, then it presents with the septicemia. If the stone passes up to the pancreatic duct, it can cause pancreatitis. Other rare complications are gallbladder cancer, Meniere's syndrome, and gallstone ETS. So, sir, when the stone is infected in the cystic duct, it causes inflammation, and this inflammation leads to blockage of the CBD. Also, sometimes this stone will cause a fistula with the CBD or duodenum. It is called Meniere's syndrome. So we will go into some studies for the natural history of the gallstones. This is from the GREPCO experience. GREPCO is a group for epidemiology and prevention of polylithiasis. So in their studies they have mentioned that they studied 118 asymptomatic patients, and they found that there is a probability of developing biliary colic 11.9 plus or minus 3 at the end of 2 years, 16.5 at the end of 4 years, and 25.8 at the end of 10 years. So, with the increasing duration, there are chances or probability of becoming symptomatic. So, it is not that patient is asymptomatic at the first time, will remain asymptomatic for lifetime. So, there is probability, and with the increased duration, there is probability of increase in the becoming symptomatic. The next study for the risk study.
What was the age group of those 108 patients? The young age, old age, middle age?
No, so they were from all the age groups. There was not particular criteria also.
It was stone detected at 30, stone detected at 60. These two are different.
Yes.
Stories, right?
Yes, sir.
Whether there was conflict of interest or not.
No, sir. This is a group for, and this group is only for the prevention of their form.
I am talking conflict of interest.
There I need to see there.
whether this group had a conflict of interest. Because they are recommending now the asymptomatic gallstone
Yes.
into surgery. Right?
Yes.
Right? And they are projecting the data.
Yes.
It reminds me 35 years back, New England Journal. 35, 40 years back. There was an editorial article was in a sarcastic manner of asymptomatic gallstone. Patient approached to a surgeon and incidentally they found a gallstone. Right?
Right.
Then he says that, but I don't have symptoms. I went for constipation and the gallstone was detected. Whether it was responsible? No. But then these gallstone can create the problem. But to me, no, not to everybody.
Yes.
See, these are the questions, sarcastic way.
Yes.
But you are likely to have gallbladder cancer. How frequently it is? No, it is very remote, Esther. But you are likely to have.
Yes.
Right? So you are making now the asymptomatic patient symptomatic. I hope now you understand.
Yes, sir. I know.
આ ગ્રુપ નો 95 પછી નો આર્ટિકલ
Such way.
I am coming to this is the story of person who invented PSA for prostate cancer. Right? And he says that I have done a lot of these studies. Those who were asymptomatic now have become symptomatic as such. Right?
Right.
You have to pinpoint the things as such, like a corporate lion, a tiger. All tigers are not man-eater. Only one tiger is the man-eater. Are you going to kill all tiger?
No.
I hope you understand me now.
Yes.
Right?
Right.
This is the natural history of all gallstone.
Right.
Right? But who is likely to be culprit is a heterogeneous group.
Yes, sir.
I hope I am putting the point.
Yes.
Otherwise, in our time there was no sonography. We are going for the lateral view of the X-ray only to differentiate between gallstone and the kidney stone.
Yes.
Right?
Right.
Huh? But when the X-ray was not there, gallstone was not there. Gallstone was there. You see? So as the investigation came as such, you are seeing more cases which are asymptomatic.
Yes.
Right?
Right.
So,
Asymptomatic means at the time of diagnosis, I think asymptomatic.
never.
No symptom.
Who knows the future?
Yes, actually.
Right?
That was the data of 1995. Now you are coming to the 2006.
Yes, sir.
Okay.
Yeah.
Right. Now coming.
Sir,
More conflict of interest.
sir, for all of my study, I don't know their conflict of interest.
See, because every article at the bottom conflict of interest.
Yes, they have mentioned, but
They don't mention.
yes.
They have to but
So they study from gastroenterologist and they have given some risk studies. So in their study, they have followed patient for median time of 17.4 years, and they have found that 19.6% participant developed some events, whether complicated or uncomplicated. So these events were related to a particular group of the patient, which they mentioned that when the stone was larger than 10 millimeter size, when there were multiple stones, when the duration of the gallstone was more than 5 years, or when the female sex was associated. So they found some points which were associated with the particular events. Not all the stones had the developed symptoms. Only 19.6% patient developed the symptoms.
How many patients are there in this?
660.
Very quickly, but 40.
Yes. And next
5 years and 20 fertile platinum female of 40.
Right.
This is the recent published study from in 2022, and this included 22,000 patients from 1996 to 2016. 22,257 patients were included, and
which country?
sorry that country.
some near the
નિયતિ ગુજરાત આ અમેરિકામાંથી તો
US કે ઇંગ્લેન્ડ હશે
Why I'm asking? Because there are authentic data by insurance company of these people. You see, they found Gallstone today, but longitudinal study, insurance company will give you the data.
Sir, this is all the study in my presentation today. I have taken it wherever these type of studies are presented in large conferences. So I have not searched it on internet only, but this in my previous and also the future studies I am going to present today. These are all which are mentioned in many of the conferences. So this is not just a random search from the internet studies.
ના that's fine but search for this patient
Yes,
population ક્યાંની છે એ ખબર હોવી જોઈએ.
Yes.
See, because when you get that, see India, there is no longitudinal study. On a health checkup you found the Gallstone,
Yes.
but what happened to this patient on a large scale, nobody knows.
Yeah.
In America you know it now, because of the insurance company. Most of them are EMR. Right? EMR is medical record. And so, after 10 years when they go for Gallstone, cholecystectomy, they know that this guy has
Manchester
Manchester, UK knows it.
સેકન્ડ થિંગ તું એકચ્યુઅલી સર્જિકલ કોન્ફરન્સમાં પ્રેઝન્ટ કર અને ફિઝિશિયન સામે પ્રેઝન્ટ કર બંનેનું ઇન્ટરપ્રિટેશન અલગ આવે સેમ સ્ટડી.
This was from 22,000 patients, and they have found that out of that 14.5% had developed symptomatic, and they also found some the cumulative incidence. They also found that 10.1% at the 5-year, 21.5% at 10 year, and after 15 years, 32.6% patient became symptomatic. Cumulative model, the female gender, younger age, because they are going to live more with the gallstone, multiple stones, gallbladder polyp, larger stones, and when chronic hemolytic anemia. So these subsets of patients became more symptomatic compared to the other patients. So after these studies, we can at least say that there are few patients, few group of the patient who have chances of becoming more symptomatic.
That was the point I was telling.
Yes.
This is a heterogeneous stone.
Yeah.
Not only cholesterol,
Yes.
pigment stone and mixed stone. Now
So-
all three behave.
So my point of saying is also that we need to identify the subsets of the group
I am putting
who
this in-
have chances of becoming symptomatic.
Right.
So my all topic is related to this only. I am not saying that all the asymptomatic patients should be operated. There are subset of patients and we need to identify them. There is one more study. Yes, yes.
What will be the SG?
Yes, sir, it is symptomatic gallstone.
Symptomatic.
Then there is one more study for gallstone size and risk of pancreatitis, and they have found that whenever the patient have at least one gallstone smaller than 5 mm in size, or 20 or more gallstones, mulberry stem, or total lower gallstone weight, because these type of stones has chances of passing to the stupidity and then to pancreatic duct and causing pancreatitis. So smaller than 5 mm stones have more than 4-fold increased risk of becoming pancreatitis. There is another study. This is from India, And they have also found some interesting that when the small gallstone size is less than 5 millimeter, there is increased chances of pancreatitis. Less than 5 to 10 millimeter also. More than 1 centimeter, there is less chances of pancreatitis.
All gallstones are of same size.
No sir, they have mentioned at least one gallstone of this size.
Gallstones are most of the time multiple.
Yes.
Right?
Right.
And all gallstones are not of same size.
Yes.
Maximum size level.
So 65% chance of pancreatitis.
Yes.
65.
Yes.
કેટલા patient
70 cases.
પણ એ તો કાઢો તો ખબર પડે ને.
પેલા એમાં જોયું સોનોગ્રાફી.
Sir, this data is from when the patient presented with the pancreatitis.
I am putting the reverse way.
All this, yes sir.
We are putting the reverse way now.
Yes.
When the symptoms develop, now you are analyzing.
Yes.
You
These
are not
are all,
analyzing asymptomatic person.
yeah. This data is post-operatively. All the patients presented with pancreatitis, all had pancreatitis, and they were operated. And from the gallbladder specimen, they checked for the stone size, and this was the result found. So, from these studies, we can at least say something that female gender, more larger stone or more smaller stone, multiple stone, young age, larger duration, longer duration, younger age and longer duration, associated with gallbladder polyp and chronic hemolytic anemia. This patient has chances of becoming more symptomatic. Now there are also small sludges when they in some USD finding there is no stone but they mention it as a sludge. Sludge mostly is due to sometimes the fasting or TPN. So we can wait for 4 to 6 weeks. Use a oxybolic acid as a prokinetic. If we are more interested, we can go for HIDA scan, which is for gallbladder function. And if the gallbladder function shows that ejection fraction is more than 40%, we can use UDCA for 3 months. After this, most of the time this sludge is clears and it is effective for cholesterol and radioleucine stone. But in this also there is chances of becoming developing pancreatitis. So this type of patient needs close observation. After most of the times 3 months the sludge clears. If it doesn't clear, we can treat him as an asymptomatic stone. Now the next question is gallbladder cancer, and most of the time it is said that gallstone is associated with the gallbladder cancer. So in this also we will go through some studies. This study best evidence covering does the presence of larger gallstone carry a higher risk of gallbladder cancer, and this in their study they have shown that larger stone when it is more than 3 centimeter size, they have reviewed the 6 studies. They go through the 3,876 papers, and from the 6 studies which were included in this, they found that larger stone more than 3 centimeter were significantly associated with gallbladder cancer. But this was the data from the foreign countries. Now this is the epidemiology of gallstone cancer, and this is published from PGI Chandigarh. This is specifically for India, and they have found that there is a difference in heterogeneity of Indian people only. From the North India to South India, their ethnicity is different. So their chances of gallbladder cancer is also different in them. In their article, some of the interesting facts were that the North India has 10 times higher probability of gallbladder cancer than the South India. Indians' average age is 51 years plus or minus 11 years, whereas in the Western world it is 70 years. Also, female to male ratio for India it is 3:1 to 4.5, whereas in South India it is only 1.6:1. Other risk factors are obesity, multiplicity, family history, rural residence, lower socio-economic status, Helicobacter infection, H-type infection, smoking, genetic factor, and porcelain gallbladder. These was from their data. So these are the subset of group also from the region we need to identify the patient. There is also a difference in the stone types from North India to South India. In the North India, more have a cholesterol and the mixed stones, whereas in South India they have more pigmented stones. So this is also a difference. So if for northern and southern South Indian people, we have different studies, and this is study from also Indians, and he has found that diagnosis with advanced cancer and most of the female are diagnosed who are at the high risk in the North India. They are diagnosed at the advanced stage only, and they require palliative care only. And there is strong association with between the long-standing gallstone disease and development of gallbladder cancer. So he has proposed that prophylactic cholecystectomy should be offered to young, healthy women who are at the high-risk region of India whenever they are diagnosed to have asymptomatic gallstone. Now this is not true for everyone. If we go in this study from the South India, they have shown that in Indian patient 60 to 90% patient is associated with gallstone, but in South only 19% patient are associated with the gallstone. And they also have black pigmented stone compared to North India where they have found the cholesterol stone. So when a patient is from South India, we don't need a cholecystectomy for each and every patient, but from the North India, we need to identify a high-risk patient and we can offer them a cholecystectomy for prevention of gallbladder cancer. Also,
it is the isolated disease.
isolated.
See the demographic difference.
Yes, yes.
Right?
Right.
So gallstone, seeing is the tip of the iceberg.
Yes.
Right? In North India, the pattern of life is different
Yes.
than the South India is.
And
See, many differences are there.
Also, sir, there was one study, I have not heard it. It was done in the Delhi only, on a worker from the different region of the India, and they also found that the results were affected from the origin of the patient. If the patient is from South India, he has migrated to Delhi, still he has lower chances of developing gallbladder cancer. Yes, compared to the person there. From the same region, they did the study and they found that the North Indian people still have higher chances of gallbladder cancer.
Genetic background.
Yes. So my study, my presentation is only to identify the subgroup of patients, not all the asymptomatic patients. Okay. So there is one reporting system was developed, and this is from the India only, from Indian authors only. They have developed a gallbladder reporting and data system to identify this type of patient based on the ultrasound finding. For this, we need a good radiologist. They have from international multidisciplinary committee comprising radiologists, gastroenterologists, surgeons, surgical oncologists, medical oncologists, and pathologists. And from the features of gallbladder wall using symmetry, extent, layered appearance, intramural feature, and interface with liver, they have developed a scoring system from 0 to 5. And from this GBRAT score, when the score is 4 or 5, he is more likely to have malignancy and needs further investigation. So, for this, we need an ultrasound. The recommendation is for 6 months for 2 times, and if the feature remains the same, then yearly follow-up of this type of high-risk patient with the ultrasound, and if there some this score is 4 and 5, then needs further investigation. Now, when it is associated with
એપિડેમિયોલોજી નોર્થ સાઉથ ની વાત કરી, ઈસ્ટ વેસ્ટ સેન્ટરમાં કઈ સ્પેસિફિક નથી.
ના સર, નોર્થ ઈસ્ટ છે, નોર્થ ઈસ્ટ એન્ડ નોર્થ both have higher chances of gallbladder cancer. Otherwise,
ભૂપતભાઈને મમતાબેનના ઘરમાં શું છે એ ખબર નથી.
In this group as such, you are restricted to you identify a patient with a red mark and go for the further investigation
Yes.
of the CT scan or MRI.
CT scan, sir. Yes.
Right?
Yes.
And then the criteria is whether they are fitting in the same way or not. That will give better answer.
Yes. So next thing is with the gallbladder polyp association with the when a stone is associated with a gallbladder polyp. So here in this study, here is mentioned that there is a presence risk factor. Presence of stone or biliary sludge is a risk factor for malignancy, but it is not as great as polyp size. So the primary consideration should be the polyp size, not the association with the gallstone. But the problem is technical, because in the ultrasound, whenever gallbladder stone is present, it handles the precise evaluation of the gallbladder polyps. So whenever the gallbladder polyp patient is on a regular follow-up and it is associated with gallstone, we are following this patient so that he does not become malignant. But it handles the precise evaluation. That's why this type of patient needs careful evaluation, and that's why this type of patient needs a special management.
Why this hue and cry? Why this hue and cry? Why this much noise for these subjects? Because when the gallbladder cancer is detected, it is always inoperable.
Yes.
Thin wall, proximity, right?
Yes.
So, it is a passport to death.
Yes.
See, this whole hue and cry is to avoid the death
Yes.
rather than anything else as such. So I am putting that subset of those gallstone which can be particularly follow up, who is a potential candidate for a gallbladder cancer. He is a subset, even though asymptomatic, needed further evaluation.
Yes.
But now they have started operating GB cancers as well.
Yes, sir. GP cancer can be
Operated is
but
it is the
primary stage only.
It's the palliative.
With liver surface, we
And
can operate, we can
પહેલા
resect the liver.
ટ્રેડિશનલ ટીચિંગ એવું હતું કે જીબી કેન્સર મળે એટલે પેશન્ટ ભૂલી જાવ,
Yes.
રાઈટ? ઇટ્સ અ મેટર ઓફ મંથ્સ.
No, you can operate.
operate કરીએ છીએ.
You can
Even
operate.
with GB, we can liver surface, we are operating and liver resection.
Liver
process.
resection, correct, yes.
So when this is a technical problem which is associated with the gallstone, that's why this need a particular attention. Now this was also studied from foreign countries. Now this study from India, and in their study they same like size more than 10 millimeters, solitary lesion, increase in size, edematous polyps, SI lesion, gallbladder wall thickening. So these are the chances of malignancy. But the incidence of malignancy is higher in patients with Indian ethnicity when age is more than 50 years, primary sclerosing cholangitis and gallbladder stone. So for Indian ethnicity, they have given a different classification, which is a Munna classification. This is from Mumbai, and they have proposed a treatment of cholecystectomy in each of these groups whenever there is Indian ethnicity is associated. We can go for routine follow-up if possible, but in the when the size is more than 10, always a cholecystectomy. 6 to 9 cholecystectomy is patient is fed or regular surveillance. Less than 5 surveillance at ultrasound, but for Indian less than 5 also they have proposed the cholecystectomy. This is from Indians only. Okay, now the next condition is chronic hemolytic anemia. With the chronic hemolysis, there is an increased chances of increased bilirubin excretion, which leads to pigmented stone, and incidence is 80% at 30 years. Also, in this type of patient, complication rate is very high, and biliary complication and veno-occlusive crisis, they both present the same way. And also, biliary complication often precipitates this veno-occlusive crisis.
This
So-
is a subgroup, once again.
Yes.
Right? All hemolytic do not behave. It is a sickle cell.
Yes, sir. Yes.
Right.
That's why I have studied for sickle cell.
Right. It is in a black population.
Yes. So this is study for prophylactic laparoscopic cholecystectomy in adults with sickle cell disease with cholecystic lithiasis. So what was their finding was that the post-operative complication rate increases in this type of patient whenever they become symptomatic, and compared to the asymptomatic patient, symptomatic patient has more post-operative complication and increased hospital stay. That's why it is better to intervene if perform perioperative specific management. It is safe and helps to avoid emergency operation for these acute complications. So this type of patient, prophylactic cholecystectomy reduces the hospital stay. So it is for the post-operative complication. Now this is another study for chronic hemolytic anemia. So they have found that this was a study for children. 46 children were included in this study. Asymptomatic were 24 were operated in asymptomatic group, and 22 after the children refused surgery and they were operated after they become symptomatic. So they observed for sickle cell crisis, and they found that the risk of emergency admission increases in the symptomatic patient. It is up to 28%. Also morbidity rate and post-operative stay. So elective laparoscopic cholecystectomy is gold standard in sickle cell chronic hemolytic anemia to prevent the potential complications and also major risk, discomfort and long hospital stay. Okay, now we come to another obesity surgery. In this study, risk factor, they have found that young patient with preoperative pain syndrome or asymptomatic gallstone before the bariatric surgery are increased risk for symptomatic gallstone disease after the surgery. So whenever the patient is going for bariatric surgery, even if there is an asymptomatic stone, there is chances of developing symptoms after the surgery. Same is true for the gastric surgery, any gastric cancer surgery or surgery related to stomach, but not other surgeries of the colon or thing. So in this study it is proposed that whenever patient is going for bariatric surgery, they should go for concomitant cholecystectomy for even asymptomatic gallstone, because it is safe and also prevents the future gallstone related complications. Same is true for the other gastric surgery, but we cannot hold this for other colon surgery or any other abdominal surgery. In the next is
one point.
yes.
We have not seen the obesity of the magnitude what waste is. Right? If somebody is having the 600 pounds of weight, how will you manage? How to carry the patient from a room to the operation theatre? How to put the patient from the stretcher to a OT table exercise?
Yes.
How to anesthetize these 600 pound patient vessels? These are all people.
Yes.
We have not seen the comorbid obesity here in India. There are special apparatus to sit the patient.
Also for CT scan,
Everything. See, it is easy to say to be done, but it is extremely difficult. Anesthetic also to get the weight in a 600 pound weight person is again a problem.
Yes.
Right? These are all technical issues as such. We recommend we go for cholecystectomy. But how to do it?
But no, sir. This is when they are going for a bariatric surgery.
I agree,
or any other
but 600 pound bariatric surgery or incisional hernia, how to manage? Bariatric comes as a surgery only. The weight is not reduced overnight.
तो 600 पाउंड ला 200 किलो છે સર 200
I am doing the same thing.
200 કિલો નો પેશન્ટ
I have seen such patients. All these methods.
250 kilos.
Yeah, 250 kilos with the incisional hernia. Now then the problem is, who will lift the patient? You see, who will put the patient on OT as such? There are special machines, lifter. All taken directly onto the operation theatre as such. OTs. How to take the veins?
So your point is, any bariatric surgery, if they have any type of gallstone, better to remove.
Yes, at that time, with the
At that time,
surgery,
yes.
not the for specifically.
Okay.
हिस्टेक्टोमी में अपेंडिक्स काटना नहीं होता
You-
हिस्टेक्टोमी में काटना नहीं है अपेंडिक्स
Okay. So another topic is along with the for the transplant patient. So transplant patients are mostly on the immunosuppression. So there is a diagnostic difficulty also. They have increased morbidity and mortality, and also these drugs, cyclosporin and tacrolimus, they are the proliferators. So what should we do in this type of patient? So should we do prophylactic cholecystectomy in transplant patient? In this study, they have mentioned that prophylactic cholecystectomy should be performed in solid organ transplant for asymptomatic cholelithiasis, but whether should we do pre-transplant or after the transplant. So for the heart transplant, they have shown that in the if the post-transplant cholecystectomy is performed, there is chances of 5 per 1000 deaths, whereas in pre-transplant it is 84,000 per 1000 deaths, and compared to 44 if the expectant management is in. So it is better to go for post-transplant cholecystectomy in this kind of patient. For the pancreas and renal transplant, there is no particular like this, and we can go for expectant management. So only for heart transplant there is an increased risk, and for this kind of patient we should go for cholecystectomy post-transplant. Pancreas and renal transplant we can wait and go for expectant management. For heart transplant, there is a specific study for US heart transplant, and this is the largest study from 1687 patients, and in this also they have shown that open or urgent emergent cholecystectomy has higher complication and respiratory failure rate compared with the laparoscopy or elective cases. This is the largest study. So prophylactic cholecystectomy post-transplant should be done electively in this type of patient of a heart transplant. So my take-home message is, only a subgroup of patients should be identified, those who are at the higher risk in a particular condition. Next is always an elective laparoscopic cholecystectomy is safe compared to an emergency open cholecystectomy, and always in this asymptomatic patient should be actively involved in the decision making, because they are not going to get any immediate benefit with this type of surgery. This is just for the prevention of future problems or any emergency condition which arises. And I would